This is Dr. Catlin again. This is the lecture recording for Module 16C, Coronary Artery Disease in your Pearson text. Coronary artery disease, leading cause of death in the United States, caused by impaired blood flow to the heart muscle or myocardium, can be symptomatic or have angina. We're going to go over angina, acute coronary syndrome, MI. We've already covered dysrhythmias. We will be covering heart failure, and we'll discuss tonight sudden death. The angina pectoris is chest pain caused by reduced cardiac blood flow. Acute coronary syndrome is unstable cardiac ischemia, and acute myocardial infarction is actual death of the heart tissue. And I said we will expand on that. Death after an MI, 60% in the first hour, 40% before hospitalization. That is why they have changed so many things with calling 911 before you start anything else to get them on their way there. Coronary blood flow regulation. It is regulated by your aortic pressure, your heart rate, metabolic activity of the heart, blood vessel tone, and collateral circulation. All that should make sense as we've spoken on and on about the heart. That's why we use different medications that are affecting different things, such as your beta blockers and your calcium channel blockers are affecting these. The medicines, ACEs and ARBs, that are decreasing your preload or your afterload, blood vessel tone with vasodilators. Collateral circulation, let me talk about that a little bit. Your heart, blood is pumping through your heart and being perfused out to your body from your left ventricle into your aorta. It's also perfusing onto itself the coronary arteries themselves to keep blood flow to the heart muscle. Collateral circulation is when those vessels, do I have a picture here? Collateral would be you have some other vessels forming here. Like here, you'll have some that are coming around, little tiny ones that can happen from partial blockages that are not real symptomatic, and the body starts forming collateral. Somebody that is very physically fit. Sometimes the collateral circulation is what keeps the infarction from being significant, or even keeping it from going from an ischemia to an actual infarction, because they have this like bypasses or collateral circulation that the body has formed. Atherosclerosis, most common cause of reduced coronary blood flow. Plaque forms affecting the different layers inside the coronary artery. We're specifically speaking of the heart now, even though it can happen everywhere in the body. We're talking about coronary artery disease. This can be caused by high levels of LDL or low density lipids, or very low density lipids. These low densities are thick plaque forming, like go eat at McDonald's and get your blood tested, and you're going to be full of these, and also triglycerides. Your high levels of HDL or high density, they're very dense, decreases the risk. I think I have the levels that you want your HDL. I always say HDL 60, 65. You want your LDL below 90. I think they say below 100, and some of them push to below 90. I teach patients your LDLs are your low, or it's your lousy cholesterol, and you want that level low. Your HDL is your healthy, heart-healthy cholesterol, and you want that level high. Atheroma is when this forms when the sclerotic thing starts to eat in here, ulcerate, and can form a clot, as you can see here. You see the blood flow coming through here is so obstructed and narrowed. That causes turbulence. Anytime there's turbulence, it obstructs blood flow, and you have a higher risk of forming a clot. Myocardial ischemia. Ischemia is when there's decreased oxygen flow, so that muscle is not getting everything it needs with nutrients and oxygen, and it starts to scream. So it has a decreased ATP because you're using all your adenotriphosphate, if you remember that from your Krebs cycle, for your energy. So your phosphate's not getting through. Because it's not getting that, there's not an aerobic metabolism anymore because the oxygen not getting through that blood supply, so it leads to an anaerobic metabolism. Lactic acid builds up, it causes that muscle spasm. If you think of it the way a runner, when you get a cramp in that muscle, because the lactic acid builds up, permeability is affected, so there's histamine and kinines and different enzymes that are released. This is in your cardiac muscle and sends the impulses to the central nervous system to pain radiating in the upper body. It's substernal, like chest bone, under the sternum. It can go to either shoulder, down the arms, most often on the left side. It can also go up into the jaw, but it presents a little bit differently in women, and we will talk about that. Oh, let me go back. The biggest thing is to reestablish that perfusion, because before the damage is irreversible. Every 30-minute delay in reperfusion has an 8% increase in mortality within a year. Okay, so the different types of angina. You have stable angina, which is the most common. It's very predictable. If they get physically active, they have pain, they stop their activity, the pain goes away. It can be relieved also with nitrates, nitroglycerin, the sublingual nitro, to dilate and open it up. Some people with a stable angina are on a long-acting nitroglycerin capsule that has to bypass the GI. We'll talk about that. Anybody with stable angina, coronary artery disease, is always to be on a beta blocker to decrease the myocardial need and oxygen demand in that heart. Variant angina, or Prince-Metal's angina, is the one that occurs at rest, not with activity. It's due to arterial vessel, coronary artery vessel spasms, not due to blockage, not due to coronary artery disease. May or may not have some blockages in there. Beta blockers are not given with Prince-Metal or variant angina because it can make the symptoms worse, because you don't want to decrease that flow in there. Unstable angina is when it occurs, Prince-Metal, it says here no, it doesn't say at night. This usually can occur more at night, sometimes during the day, but it's more common at night. Unstable angina is when your angina is becoming increasing in frequency, duration, and severity. That's why it's unstable. It's no longer called stable angina. It can even occur at rest rather than just with activities. This is showing an increased risk for myocardial infarction. First line of treatment is nitroglycerin. And you can have myocardial ischemia without having any angina. So your angina clinical manifestations with the stable: pain, rest, relief. Described as tight squeezing, heavy pressure, a constriction sensation, behind the sternum, rating the jaw, neck, shoulder, or arm. It has a crescendo decrescendo pattern, meaning it gets bigger and then lesser, lasting anywhere 2 to 5 minutes, where the unstable lasts for a longer period of time. Relieved by rest. This is stable angina again. Possibly have some dyspnea, pallor, tachycardia, anxiety, and fear. You can look in your text on page 1190, which goes over these. It also goes over cholesterol levels on their manifestations in angina, box 16.9. Also look at table 1618, talks about triglyceride and cholesterol levels. Anyway, back to here. Women often have atypical symptoms: indigestion, nausea, vomiting, fatigue, and upper back pain. Our anatomy is different, our body is made different. So unfortunately, because of presenting differently, often it is missed in women or delayed in treatment and can lead to worse outcomes. So I talked about angina. Now we're going to talk about acute coronary syndrome. Coronary blood flow is significantly reduced but not fully occluded. So some blood is getting through. It can be due to plaque, a thrombus that's formed, combination of the two, a coronary artery spasm, even though it's that princemetal angina or variant angina. If the spasm is significant, if it obstructs enough of the blood flow for enough period of time, it can cause some ischemia. This leads to acute coronary syndrome can lead to inflammation of the coronary artery, and it just increases myocardial oxygen demand, and it may lead to a decrease in blood supply, or oxygen transfer. Majority affected with acute coronary syndrome have significant atherosclerotic occlusion of one or more coronary arteries. This is where I don't have an EKG tracing here. Remember your PQRST, your T segment is depressed. That's with the thumbs down. When I said it's ischemia, the body is screaming, yelling, the heart muscle is saying, I need some oxygen. The more it's deprived, you start seeing an elevation in the ST segment. It has not died yet, but there is an elevation, and I have some strips later in this lecture. Clinical manifestations: substernal or epigastric. This is acute coronary syndrome. Substernal or epigastric chest pain, often radiating to the neck, left shoulder, left arm. Lasting longer than 10 to 20 minutes. Notice the difference between angina lasting 2 to 5 minutes. It still may radiate, but it doesn't last as long. Angina usually is occurring with rest. When you're in acute coronary syndrome, it can occur at rest. More severe and prolonged than previous experienced. This is when you think about your unstable angina, dyspnea, diaphoresis, pallor, cool skin, lightheadedness may occur. They can have tachycardia and hypotension as the blood flow is further and further obstructed. Then you lead to your acute myocardial infarction, where the blood flow to a portion of the cardiac muscle is completely blocked. There's a lack of oxygen. Nutrient causes injury to the myocardial cells. That lack of adequate blood flow changes the pumping on the heart's ability depending on where it's affected, and usually often affects the left ventricle. It's prolonged tissue ischemia and leads to irreversible cell damage. If, as I mentioned earlier, good collateral circulation can limit the size of the infarcted area or myocardial infarction. Often affects the left ventricle. You don't need to know which artery effect causes which type of MI, but just know that the occlusion of the left main, you'll hear people call left main coronary artery, is the most devastating and often leads to death. Acute cocaine intoxication or toxicity can actually lead to an MI. We talk about that more with your cardiomyopathy. It may or may not cause permanent damage, but it can, it's one of those drugs that can cause an MI. Clinical manifestations of acute myocardial infarction or heart attack or MI. Chest pain of sudden onset, not precipitated by ordinary physical activity. Substernal of precordial, may radiate to neck, shoulder, arm, and jaw. I remember the first MI I took care of only had pain in his jaw, not in his chest. Tachycardia, tachypnea, dyspnea, shortness of breath, nausea, vomiting, diaphoresis. Anxiety, a sense of impending doom. You notice a lot of these sound a lot like your pulmonary embolus. Cool, mottled skin, decreased peripheral pulses, palpitations, dysrhythmias, decreased level of consciousness, hypotension. Remember these last 15 to 20 minutes and not relieved with nitroglycerin or rest. So now we're going to get into seeing what's actually happening in the heart and looking at your EKG tracing. When I talk about the different levels, you have this whole heart wall muscle. So you can have some ischemia out here where there's some obstruction leading to injury, and the infarction depends on how deep it goes. So transmural, it goes all the way through. You'll see here you have your isoelectric line. So all your tracings should come back to that isoelectric line. Here's your ischemia, or your thumbs down, your ST segment depression, where it's the thumbs down saying I'm in trouble. And then you have, when it's going all the way through, a better picture. I think I've shown you a better picture. The next slide is a better picture with this elevation. The ischemia is spreading, and then you see in this next slide, there's your tombstone where it actually leads to tissue death. So you're normal, I'm in trouble, I'm in more trouble, I start to elevate, and then you have your tombstone or tissue death. It can take anywhere from 1 to 6 hours if the blood flow is not restored to that area, leading to this complete infarction through the transmural, through the different layers. You will hear people talk about STEMIs and non-STEMIs. This is what they're referring to. You have a ST elevated myocardial infarction, STEMI, ST elevated myocardial infarction, STEMI. Non-STEMI is a myocardial infarction that does not lead to ST segment elevation. You can have this ischemia and it leads to a death in part of that tissue, but it doesn't go through all the layers transmural. But there is actual some tissue death in there following that ischemia. It just isn't all the way through. It's what somebody might refer to as a mild or small MI or heart attack. Things you cannot change: age, greater than age 65, gender, male greater than female, younger age, men starting age 45, females usually 55 or postmenopausal. Race and ethnicity, socioeconomic factors all contribute to the risk factors, especially family history. Highest risk if there's a first degree relative that had heart disease at a young age. So if you have a first degree relative, a parent or a sibling that had heart disease starting, if it was a male parent, a male relative, parent or sibling that had it before the age 45, or a female first degree relative that had it before the age of 55, or other significant family history running through. Risk factors that are unique to women: menopause, whether it is through surgery or natural menopause. estrogen replacement therapy actually reduces risk. For many, many, many years, they said there was a study saying that women should not have estrogen replacement because it increased the risk of having a heart attack, and now they found it actually decreases its protective. But then an oral contraceptive with estrogen, it increases the risk of a clot and leading to a possible myocardial infarction, but estrogen replacement therapy after menopause decreases risk. Women that smoke are higher risk for myocardial infarction if they're age 35 or older, smoke, and are on oral contraceptives. That actually is a contraindication to oral contraceptives with estrogen because of the MI risk and DVT risk. So some things are working on this elevated serum homocysteine level. Homocysteine is an amino acid used to make protein. Normally, vitamin B12, B6, and folic acid break down this amino acid and change it into substances that your body needs. So your homocysteine levels have been used up and should be very low. When somebody is deficient in B12, B6, and folic acid, they have found that can cause elevated homocysteine levels, or even without that, an elevated homocysteine level increases your risk for an MI. Interestingly, when they've tried lowering the homocysteine level by giving folate, increasing their folate intake, somehow that is not decreasing the myocardial risk, so not sure. Okay, so aspirin antiplatelet therapy decreases risk. Somebody might be on Plavix or clopidogrel for the antiplatelet therapy, or low dose aspirin, the 81 milligram aspirin. Sometimes they're up to the 325 milligrams. That is, the aspirin therapy is good, but then you have risk and benefit that outweighs each other. When somebody reaches age 60, 65, the risk for bleeding outweighs the benefits. And inflammation, anything that causes increased inflammation increases the risk for myocardial infarction. It may be any inflammatory disease, or inflammation can be caused by plaque buildup. Metabolic syndrome is another risk factor, and I will be talking a little bit on the next slide here about metabolic syndrome. It is a I guess 2 slides before I talk about metabolic syndrome, sorry. Okay, so modifiable risk factors, those are things you can reverse, like in so many other things: diet, activity level, obesity, cigarette smoking, hypertension, diabetes, and hyperlipidemia, which almost all of these are part of your metabolic syndrome. So diet, you want diets high in fruits, vegetables, whole grains, unsaturated fats. These can be protective. Activity level, regular activity level, 15-20 minutes of elevated heart rate 5 times a week. Obesity. It's not just obesity, it's also fat distribution. So a BMI greater than 28, and then is overweight. A BMI of 30 or higher is obese. The higher the BMI, the higher the cardiovascular risk and the risk of plaque. Also truncal obesity, when they have that pear shape where the weight is in the middle, is a risk factor. Cigarette smoking, males are 2 to 3 times. Males that smoke have a 2 to 3 times higher risk of a heart attack. Females that smoke have a 4 times higher risk of having a heart attack. For every year that somebody has quit smoking, reduces the risk of an MI by 50% than a smoker. Hypertension stimulates plaque development, increases the risk. It also stimulates that inflammation. Diabetes increases other risk and contributes to the atherosclerosis. Hyperlipidemia, I talked about HDL. You want your HDL 60 or greater to become protective. HDLs that are below 40 for men and below 50 for women increase risk. The lower the HDL, the greater the risk. So people with HD, they might have a wonderful cholesterol, wonderful triglyceride level, total cholesterol level, a decent LDL level, but their HDL is in their 20s. That in itself is a risk factor. An elevated LDL with an elevated triglycerides above 150 are a risk factor. So now I'm going to talk about metabolic syndrome. Apologize for that. It is a syndrome. It is not a disease. If they have 3 out of 5, metabolic syndrome is a huge risk factor for myocardial infarction. So the low HDL, visceral obesity, that truncal obesity I talked about, insulin resistance or diabetes, and the type 2 diabetes, and I can't think of it, insulin pre-diabetic with a hemoglobin A1C of greater than 5.8. So hypertension and high triglycerides, 3 out of the 5 is diagnostic. There is actually a diagnosis of metabolic syndrome. So your diagnostic tests or your cardiac markers, your CK, creatinine kinase, MB, CK-MB. Creatinine kinase is released by a damaged muscle. CK-MB is the enzyme that is released specifically for the heart. There's several different kinds of CK. CK-MB is specific for the heart. It can take 4 to 6 hours for these to show up. So been a nurse a long time. Before we were able to measure troponin levels, we'd watch for the CK-MB elevation, which could be 4 to 6 hours. And that's why you do your CK-MBs in series, also your troponins. You watch, they'll do them and they'll do them in 6 hours and 6 hours and 6 hours or 4 hours. They'll watch for a peak and for it to come back down to show that the damage has stopped. Troponin is a protein released during a myocardial infarction, so that makes the troponin levels very sensitive indicator of a myocardial damage. So that's where they'll talk about a non-STEMI. EKG may be showing some depression, but you have positive troponins, so you know you actually had cardiac damage, and that's when they'll say they had a non-STEMI, non-ST elevation myocardial infarction. Myoglobins are also released with an MI. You're monitoring your CBC, often with an MI they have an elevation of their white blood count, at least initially. Watching arterial blood gases for perfusion, looking at acidosis, alkalosis, other problems. Echocardiogram, I've talked about those, looking at your cardiac wall motion, left ventricular function, looking at valve function, looking at your cardiac output. Radionuclide imaging evaluates the myocardial perfusion, but it cannot differentiate whether it's an old or new myocardial infarction. Sometimes with that is where they see that somebody's had an MI, although nothing's showing now, so they had one sometime in the past. Hemodynamic monitoring, I think I've mentioned, I know I talk about it in your cardiomyopathy and your heart failure, measuring pressures within the different chambers of the heart. Also your O2 sats, or your perfusion through your pulses, through arterial lines for interarterial pressure readings. Let's see. Let's get into some medications here. Anti-anginal agents, your nitrates. Large first pass effect, that's why you don't have just a pill that you can swallow. They do have some extended release that goes past, does not start breaking down till after it's through the stomach, otherwise it's useless. That's why your nitroglycerin is given sublingual, topically in an ointment, or in an IV. Nitroglycerin is taken by patients with a history of chest pain, of cardiac origin, because it dilates the coronary vessels, contraindicated in low blood pressure, or taking any medications for erectile dysfunction. Watch for drop in blood pressure. Another side effect not listed here is headache, because nitroglycerin, although it dilates the coronary vessels, it also dilates other vessels, and pounding headache and hypotension. This is just the slow release, the NitroBid patch, nitro ointments. You have your sublingual, I think that's your transdermal. Some teaching, we've covered this in the past. Keep the bottle with the patient at all times in a closed amber bottle. It is sensitive to heat and light. That's why the bottle's dark. They are not to transfer it to different bottles. If you're hanging nitroglycerin, it's going to be wrapped in something or in a dark bottle also for your IV nitroglycerin. It's not a pill that you're going to lay out. Also teach them not to keep it in their glove box. They can keep it in their pocket near their body. I had that in Florida a lot, where they kept it in their glove box, and the heat destroys its effectiveness. They should have a tingling or burning sensation on their tongue when the nitroglycerin is effective. If they've opened a bottle, they need to throw it away after 2 years. Sooner if it's not causing the tingle. Somebody that has angina may use this before their exercise or sexual activity, walking or whatever, to dilate the vessels to prevent that angina. They are to take the nitroglycerin at the onset of chest pain. They are to take one every 5 minutes, up to 3. They used to say wait to the 3 to call 911. Now it is to take the nitroglycerin. If the pain is still there in 5 minutes, take another one while you're calling 911 and lay down and rest. If you're taking a long-acting nitroglycerin, plan it so that it is not on during rest time, bedtime. Male clients should not take nitroglycerin if they're on erectile dysfunction medications, and I've said that before. Okay, acute myocardial infarction. We used to say MONA. We'd say morphine, oxygen, nitroglycerin, and aspirin. They're not saying so much about the nitroglycerin for the acute myocardial infarction. At this point, I don't know why. Morphine is your drug of choice. Aspirin, thrombolytics if it's within the 6-hour onset. Antidysrhythmic agents, which we've covered before. Oxygen at 2 to 5 liters. Bed rest. Limit any extremes in temperature, hot or cold, and limit the caffeine. Remember, your acute myocardial management is part of your teaching. If you have a person that has had a myocardial infarction, they have significant coronary artery disease, they have angina, part of your teaching is teaching them to take that aspirin, the nitroglycerin. If they have oxygen at home, they to rest and call 911. Drug classes for lowering cholesterol, your statins, bile acid sequestrants, niacin, fibric acid agents. You should have notes of them from Pharm 1. If you need more of those notes, just let me know. Revascularization, PTCA or percutaneous transluminal coronary angioplasty. A catheter goes in, usually through the femoral. They go in with the catheter. There's a balloon that goes into where the blockage is. They open the balloon to press the blockage to the sides. They put a stent in there. The stent keeps it open. Remember, if I mentioned, oh no, I don't know if you listen to DIC yet, when I think I mentioned stents in there, why they'll be on a Plavix or clopidogrel, after a stent placement because the stent is a foreign body in the vasculature and it can stimulate the DIC. Okay, so coronary bypass graft, they literally do a graft. I'm going to go back to your heart picture at the very beginning. Here, so suppose we have a blockage in this here. They will take usually a vein from the leg, vein from somewhere, often from the leg, sometime in the mammary, right from inside when they're in the chest. So the blockage is here where the O is. They will sew it here and sew it here. So the blood will come and will bypass the blockage. I got to get back to where we were. And I passed it. Okay. Yeah, it says use a vein or artery, 90% totally relieved, reduces angina. The heart literally stops during the surgery. They're doing more minimally invasive coronary artery surgeries now. Transmyocardial laser revascularization I've not seen done. They actually drill tiny holes in the myocardial muscle to provide blood flow in the ischemic area, and I'm not real familiar with that. Myocardial infarction in women, more likely to have silent or unrecognized heart attack. As I mentioned, they might just present in cardiac arrest or cardiogenic shock. The atypical symptoms, epigastric pain, indigestion, nausea, vomiting. They tend to think it's heartburn, gastroenteritis. They might present with shortness of breath, fatigue, weakness in the shoulders and upper arms. All these things will delay understanding what it is, so their outcomes are worse. Myocardial infarction in the older adult commonly have atypical symptoms too. If you think of weakness in the arms, it might, or confusion, dropping something, it can be attributed to age, contribute to a stroke when it's actually a myocardial infarction. Also, because of atypical pain, just like with the female, they may not seek treatment right away, and it can lead to worse cardiac damage, complications, and even death. They have a decrease in their nerve endings or the flow, so that can also inhibit, especially if they're diabetic, inhibit the nerve impulse sending the message that they're in pain. The older adult often has difficulty breathing, confusion, fainting, dizziness, abdominal pain, and cough, and that's why it is often silent and missed, leading to worse outcomes. Your physical assessment, vital signs, height, weight, BMI, heart sound, skin color, temperature, level of consciousness, cardiac rhythm, abdominal assessment. If they're presenting with abdominal pain, do they have abdominal aortic aneurysm? Are they in some kind of heart failure? Or is it actually a referred pain because it's cardiac? This is a really good mnemonic for assessing chest pain. Just remember your EKG rhythm, your P, Q, or S, T. So P for provocative or palliative, what makes a symptom better or worse. Q for quality, describe the symptoms. R for region or radiation, where in the body does the symptom occur? Does it radiate? Or extension of the symptoms to another part of the body. S for severity, on a scale of 1 to 10, 10 being worst, how bad is it? T for timing, does it occur in association with something else, eating, exertion, movement. Also make a note, cardiac related fatigue is worse in the evening. Fatigue related to anxiety or depression is worse in the morning. So if you go back with your the elderly person can have fatigue. The female often will have fatigue, maybe one of their only signs, even though the male can have the fatigue. But if you're assessing for cardiac versus something else, cardiac related fatigue is worse in the evening. anxiety and depression fatigue is worse in the morning. And that is the end of this recording.